in Japan. My presentation is entitled Trends in Management of Rotator Cuff Repair, and I will talk about the recent progress of arthroscopic trans-osseous rotator cuff repair. Background. The anchor method is the mainstream for arthroscopic rotator cuff repair. However, a suture anchor is too expensive. For some people. In addition, the multiple anchors in the greater tuberosity can make reoperation difficult in Retear cases, and sometimes anchor detachment occurs. In 2005, we developed arthroscopic trans-osseous suture without implant for rotator cuff tears to overcome these issues of anchor method. This technique is abbreviated as ATOS. ATOS uses a long straight bone tunnel and new simple knot tying technique at the lower part of the greater tuberosity, where the bone cortex is solid. I will introduce the details of ATOS technique and the postoperative outcomes. From April 2005 to April 2015, all non-absorbable polyester sutures were used. Since May 2015, absorbable polyglycolic acid, abbreviated as PGA, has been used for mattress suturing. Overview of the ATOS technique. After the rotator cuff is pulled towards the footprint with two absorbable mattress sutures, it is pressed down to the footprint using three non-absorbable bridging sutures. ATOS is performed with the patient in the lateral position and with a 2 kg indirect arm traction. We use 5 portals: anterior, anterolateral, lateral, posterolateral, and lower portals. The lateral and posterolateral portals are used mainly for viewing. The anterolateral and lower portals are used mainly for operating. The suture strength depends on the bone strength of the lower part of the greater tuberosity, not on the footprint. So sufficient bone cortex is shaved off until the bone marrow is exposed. The following technique is unique to ATOS. The aiming tip of the Kirschner wire guide is applied to the medial border of the footprint, and 3 Kirschner wires with perforated tips are inserted from the lower part of the greater tuberosity to the medial margin of the footprint. The first Kirschner wire is inserted. The aiming tip of the drill guide is applied to the anteromedial border of the footprint. The second Kirschner wire is inserted into the mid-medial border of the footprint. The third Kirschner wire is inserted into the posteromedial border of the footprint. Now, the three Kirschner wires with perforated tips were inserted at the medial border of the footprint. The Kirschner wires are advanced, penetrating the rotator cuff and then the skin, while pulling the rotator cuff stump outward. The rotator cuff stump is pulled laterally. The Kirschner wire penetrates the rotator cuff and then the skin. The second Kirschner wire also penetrates the rotator cuff and the skin, although it penetrates the acromion on the way. This does not cause any problems. This is the third Kirschner wire. The three Kirschner wires, which have penetrated the greater tuberosity and the rotator cuff, are aligned outside the skin. A nylon suture attached to the 65 cm number 2 non-absorbable polyester suture and the 65 cm absorbable PGA suture is passed through the perforated tip of the posterior Kirschner wire. It is pulled out through the lower portal, passing the rotator cuff and posterior bone tunnel. The polyester and PGA sutures, which have been pulled out, are noted. The distal part of the PGA suture is cut and pulled upward. Then, the knot is anchored on the lower part of the greater tuberosity. The nylon loops connected in series are passed through the perforated tip of the central Kirschner wire and pulled out through the lower portal, passing the rotator cuff and the central bone tunnel. These nylon loops are later used to pass the mattress sutures and the central bridging suture through the central bone tunnel. A nylon suture attached to the 65 cm polyester suture and PGA suture is passed through the perforated tip of the anterior Kirschner wire. It is pulled out through the lower portal, passing the rotator cuff and the anterior bone tunnel. The polyester and PGA sutures, which have been pulled out, are noted. The distal part of the PGA suture is cut and pulled upward. Then, the knot is anchored on the lower part of the greater tuberosity. Two sets of polyester and PGA sutures that pass through the greater tuberosity, rotator cuff, and skin are now set in the anterior and posterior of the rotator cuff. The nylon loops connected in series have been placed in the central bone tunnel for relay. The blue lines labeled as A, B, and PB in the schematic view are anterior and posterior polyester bridging sutures. The red lines labeled as M are PGA sutures for mattress suturing. The black lines labeled as N are nylon loops connected in series. The next step is suture relay. Posterior PGA suture, anterior PGA suture, and the central nylon loops are extracted through the anterolateral portal. Two PGA sutures for mattress suturing are passed through the nylon loop and relayed to the lower portal passing through the central bone tunnel. The nylon loop is returned to the anterolateral portal, and 65 cm polyester suture for central bridging suturing use is relayed to the lower portal, passing through the central bone tunnel. These are the two PGA sutures for the mattress suturing. These two PGA sutures are ligated with square knot using a polyester suture. Next, this ligature is twisted around the mattress sutures and ligated by square knotting. This process is repeated. This knot is inserted into the greater tuberosity and tightened. You will notice that the rotator cuff is drawn laterally by the mattress sutures. Here, the two mattress sutures are completed at the same time. In this stage, the anterior, central, and posterior polyester limbs for bridging suture use remain above the rotator cuff. Central bridging suture. This is one limb of the 65 cm polyester suture for the central bridging suturing that passes through the central bone tunnel. Another limb of the polyester suture on the rotator cuff is pulled out through the lower portal along the lateral wall of the greater tuberosity using a suture penetrator. This limb and the other limb passing the central bone tunnel are ligated with square knot using polyester suture. Next, this ligature is twisted around the central bridging suture and ligated by square knotting. This process is repeated again. This knot is inserted into the greater tuberosity and tightened. The end of the rotator cuff are drawn to the lateral border of the footprint and then pressed down to it. Anterior bridging suture. This is one limb of the anterior bridging suture that passes through the anterior bone tunnel because the another polyester limb for anterior bridging suture use on the rotator cuff cannot be pulled out directly through the lower portal. It is once pulled out through the anterolateral portal. Next, it is pulled out through the lower portal. This limb and the other limb passing the anterior bone tunnel are ligated with square knots using a polyester suture. Next, this ligature is twisted around the bridging suture and ligated by square knotting. This process is repeated. This knot is inserted into the greater tuberosity and tightened. The anterior portion of the rotator cuff is also drawn laterally and pressed down to the footprint. Posterior bridging suture. the polyester rim for posterior bridging suture use on the rotator cuff also cannot be pulled out directly through the lower portal. It is once pulled out through the anterolateral portal, and the same process as the anterior bridging suture is repeated. Tightening up and locking the knots. The mattress and 3 bridging sutures are further tightened and secured by 3 half-hitch knots. This is the mattress suture. It is tightened up. You can see that the rotator cuff is tightened further. After tightening up, it is secured by 3 half-hitch knots. Anterior, central, and posterior bridging sutures are also further tightened and secured by 3 half-hitch knots. By doing this, the knot security exceeds 130 Newton. Here, we can see the 2 absorbable PGA mattress sutures and the 3 non-absorbable polyester bridging sutures. The 2 mattress sutures and the 3 bridging sutures compose the basic unit. However, the mattress suture and bridging suture can easily be added by placing the aiming tip of the wire guide on the rotator cuff after suturing. When the AP diameter of the rotator cuff tear exceeds 3 cm, we add 2 bridging sutures. The mattress suture relay and knot tying technique may be confusing, so I'll explain them in a little more detail. One limb of the anterior mattress component is anchored to the inferior margin of the greater tuberosity, passing through the anterior bone tunnel, the rotator cuff in the opposite direction, and then the central bone tunnel. One limb of the posterior mattress components is anchored to the inferior margin of the greater tuberosity, passing through the posterior bone tunnel, the rotator cuff in the opposite direction, and then the central bone tunnel. These limbs do not slide and come from the same central bone tunnel. Therefore, we cannot use sliding or static knot here. This issue was resolved by tying the mattress component with polyester suture using square knots. The knot of number 2 polyester suture is not drawn into the bone tunnel by repeating the square knotting process 3 times. As per the preliminary experiments, the knot does not slide up to a tension of 28 Newton, and knot security exceeds 130 Newton by adding 3 half hitches. After surgery, we use soft brace for 4 weeks in 45 degrees flexion and 45 degrees internal rotation. Passive elevation by physiotherapist was started 2 weeks after surgery. Active elevation was started at 4 weeks and driving at 6 weeks. If the rotator cuff tear exceeds 3 cm, these durations were extended by 2 weeks. From 2015 to 2019, we performed ATOS in 471 cases. Of these 389 patients who have been followed up for more than 2 years are the subjects of this study. 199 women, 190 men, 266 right, 123 left. Average age at the surgery, 65.7 years old. The surgical time was 49 to 208, with an average of 116 minutes. Small tear with medial to lateral diameter less than 1 cm was 74. Medium tear of 1 cm to 3 cm was 249, and large tear more than 3 cm was 66. Clinical outcomes were assessed on UCLA score 2 years after surgery. All 4 subscales, pain, function, forward flexion, strength of forward flexion, improved significantly after surgery. The mean preoperative and postoperative UCLA total score were 20.6 and 34.1, respectively, in patients with small tears. It was 19.9 and 32.9 in medium tears, and 18.3 and 32.1 in large tears. The total postoperative score was significantly higher in the small tear than in the medium and the large tear. The UCLA total score improved from 19.7 out of 30 before surgery to 32.9 out of 35 after surgery. Excellent with 34 to 35 point was 62.2%. Good with 29 to 33 points was 29.1%. And poor with less than 29 points was 8.7%. As shown in the slide, the minor and major discontinuity of the T2-weighted image of MRI 1 year after the surgery was diagnosed as Retear. The Retear rate was none for small tears, 0.8% for medium tears, 7.6% for large tears, and 1.8% overall. The axillary nerve must be protected during this ATOS repair. When Kirschner wires are inserted distally to the axillary nerve, entrapment by bridging suture is inevitable. To prevent axillary nerve injury, we identified the neurovascular bundle via preoperative MRI and inserted the Kirschner wire 1 cm above the neurovascular bundle. The crossing angle of the line connecting the medial edge of the footprint and Kirschner wire insertion point, and line perpendicular to the humeral shaft, is the proper insertion angle. The angle is commonly 60 to 65 degrees. Postoperative MRI showed that the neurovascular bundle and Kirschner wire insertion point are distant from each other. Based on postoperative EMG of the deltoid muscle, there was no axillary nerve injury. Economic benefits of ATOS repair. In 2019, the anchor method of 25,519 cases was performed in Japan, and 80,943 anchors were used. Therefore, 3.2 anchors were used in one anchor repair. In Japan, the standard price of anchor is $319, so the cost of surgical materials for the anchor method is $1,021. On the other hand, PGA and polyester sutures to be used in ATOS repair are only $12. This is a table summarizing the reports of arthroscopic trans-osseous rotator cuff repair in more than 50 cases. In 2006, Mattress reported a Retear rate of 12% for the hollow needle method. In 2010, Hubert reported that the hollow needle was $121, and the Retear rate was comparable to the open repair. Duquin reviewed 1,252 cases in 2010. Results showed that the Retear rate of the double row anchor method ranged from 7 to 41%. According to Kuroda's calculation, the cost of surgical materials for the anchor method is $1,021. In addition, Retear rate after open repair was 17 to 44%. In 2016, Flanagan reported that the arthrotanura was $600 and the Retear rate was 3.7%. The Retear rate of ATOS was 1.8% and the material cost was $12. ATOS achieved the lowest Retear rate with the lowest cost. 24 years ago, Burkhardt reported that Trans-Osseous suture repair was inferior to anchor method as a result of cyclic loading. However, the Trans-Osseous suturing used in his study was simple bone suture on the lateral margin of the footprint. In this area, the bone cortex is weak. It is substantially different from ATOS, which combined a long bone tunnel extending from the lower part of the greater tuberosity to the footprint, with 2 mattress sutures and 3 bridging sutures. Therefore, his conclusion is not applied to our technique. As Park mentioned, in rotator cuff repairs, Trans-Osseous sutures may generate a greater bonding force than anchor suture. And Ahmad reported that because suturing restricts rotator cuff movement, Trans-Osseous suturing is advantageous in rotator cuff repair. In Trans-Osseous repairs, such as giant needle, hollow needle, and arthrotanura method, the weak bone tunnel is a disadvantage because the bone tunnel is created in the upper part of the greater tuberosity with a thin bone cortex. In 2018, Liu showed that the incidence rate of intraoperative bone laceration in surgery using the arthrotanura was 44%. In ATOS procedure, mattress sutures are used to firmly secure the rotator cuff at the inner edge of the footprint. Thus, the cuff is subjected to strong compressive stress at the outer edge of the humeral head. The bonding process between the rotator cuff and the footprint progresses and the rotator cuff achieves adequate stability in 3 weeks. To avoid the long-lasting strong anchoring force, we used absorbable mattress sutures. The tensile strengths of PGA sutures were 65% and 35% after 2 and 3 weeks, respectively. Preventing unnecessary suppression of rotator cuff movement reduced the repair rate. However, there is no historical evidence for this hypothesis. This is a limitation of this study. The factors of low retear rate of the 8th procedure. 1. Complete decortication of the footprint provides an ideal bonding condition between the rotator cuff and the footprint. 2. Required 3 bone tunnels with a diameter of 2 mm can provide the maximum contact area. 3. Absorbable mattress sutures avoid long-lasting excessive stress on the rotator cuff. Advantages of 8th repair. 1. Low surgical material cost. 2. Low retear rate. 3. Excellent clinical outcomes. 4. No implant in the greater tuberosity makes easy reoperation. Thank you for your attention.
Thank you very much, Professor.
Thank you for watching my video.
Just one question from our side. Do you have any patients who developed axillary nerve injury?
No, I have not experienced the axillary nerve injury.
Okay. Any technical tip to reduce the incidence of injury?
I certified the axillary nerve via preoperative MRI, and I chose the safety insertion angle of the Kirshner wire.
Thank you very much, Professor. I think that's all the questions that we